Paediatric Gecko session of the year. We run these sessions every week on a Wednesday afternoon. It's hosted in South Africa by the Gastro Foundation in conjunction with Project iEcho from the University of New Mexico. So we have a session every week, and every about 8 weeks, it's pediatrics' turn. And this is the last pediatric session for the year. So welcome to it. Can I ask the chat will be open to questions, or otherwise write them down and keep them till the end of the talk, and you can put your hand up. So today we've got Dr. Mudau talking to us about autoimmune hepatitis in children. And Dr. Mudau hails from the Wits Donald Gordon Medical Center, where she's attached to the Transplant Center. And she's also a pediatric GI fellow and is about a year into your time, Vusi? Somewhere there. Okay. So we look forward to your talk. I'm not sure if you can start screen sharing.
Okay, let me do that. Okay, can you see my screen?
Perfect. That's perfect. Thank you.
All right. Good afternoon, everyone. As Tim already said, I'm Vusi, and today I will be talking about diagnosing and management of pediatric autoimmune hepatitis. I will also go through one of the cases that we've had recently in the ward. So autoimmune hepatitis is a chronic inflammatory disease which is said to have an infectious or environmental trigger in a genetically predisposed individual that is associated with an aberrant chronic autoimmune response. And this response targets the hepatocytes and or the cholangiocytes. Most epidemiological studies have been done in Europe and North America, and they report incident ranges of pediatric autoimmune hepatitis to range between 0.1 and 1.9 per 100,000 population per year. Epidemiology of pediatric autoimmune hepatitis in South Africa is not known at the moment. There have been studies done in parts of Africa, 2 in Egypt, 1 in Ghana, and 1 in Cape Town, South Africa. And all of these 4 studies that I came across actually didn't mention what the actual incidence of autoimmune hepatitis is in this patient populations. However, the things that they had in common was that type 1 autoimmune hepatitis was the most common, and that the disease had a female preponderance. So I'll just go through my case. So we had a 13-month-old little girl. She's a child that was previously well, normal growth and development, and she was attending creche. She was referred from a GP where she consulted there with a 4-day history of jaundice, fever, and a single episode of vomiting. There was no diarrhea, but there was a report of colic stools. There was no history of chronic medication use. However, the mom did say she was given Panado and Constant for the fever. Her immunizations were up to date. However, hepatitis A vaccine was not given yet. There was no travel history. There were no sick contacts at home. Mom did report that she had cousins that were known with thalassemia. Okay, so on examination, this child generally looked well, but she was jaundiced. She didn't have clubbing. She was not encephalopathic at the time. She had a soft abdomen with no hepatosplenomegaly or ascites. So these are the blood results that she came with when she came through from the private GP. So they had done just a liver function test, which showed a significant transaminitis. Her bilirubin levels were also elevated, as well as an elevated gamma GT, but predominantly this was a hepatitis with elevated transaminitis. Her hepatitis B and A were negative. They did screen for thalassemia. So they did just an HB electrophoresis because of the history that there was family members that have thalassemia. They thought maybe that could be the cause of the jaundice. At the time when she was referred to us, she also had an INR of 2. She had elevated triglycerides of 3.9 and her ferritin was 496. This was in 2020. She was tested for COVID and that was negative. When she came through to us, we repeated her bloods, which still showed that she had a significant transaminitis. These were done a day after she was, after the initial blood. So she still had a significant transaminitis. We then went on to exclude Wilson's disease. We excluded other viruses. We also did a history of drugs, and there was no drugs that were reported that she was taking, but there was a tox screen that was done, which was negative. So of significance for this child is that when we looked at her blood, she had a very elevated liver kidney anti-liver kidney microsome antibody with titers of 1 in 1,280. But also of note, with this very elevated autoantibody, which is suggestive of autoimmune hepatitis type 2, we looked at the rest of her liver function test and actually noted that her globulin gap was actually not elevated and her total immunoglobulins were also not raised. So we also proceeded on to do a liver biopsy for her, which at the time they had said that the features of the biopsy were those of mild portal tract expansion with lymphocytes and histiocytes. There were no plasma cells or granulomas. There was no viral cytopathic effect that was noted. They did note some areas of interface activity, but this was said not to be prominent. So they had, at the end, concluded from the biopsy that the features were in keeping with a viral hepatitis. So in terms of managing her in this state, when she initially presented, while we're still waiting for the autoantibodies to come, we thought she was an immune dysregulation based on the fact that her triglycerides were up, her ferritin was up, and those deranged enzymes as well. So she was given a methylpred pulse, to which she actually responded quite nicely. A diagnosis then, after everything was out, of type 2 autoimmune hepatitis was actually made, and she was discharged home on prednisone. We watched the liver function trend, and it showed improvement, with improvement in her PDs as well. And then we later on added azathioprine to her treatment. So 2 years into the treatment, as you can see, the results trend from your left to the right actually showed that she was actually quite doing well from a biochemical point of view. Her enzymes had settled to completely normal. So last year, November, she presented again with flu-like symptoms and fatigability. And on questioning at the clinic, the parents actually admitted to the fact that they did their own research and they saw that treatment could actually be stopped if their child was doing well at 2 years. So they went ahead and they had stopped treatment prior to this presentation without any medical advice. So as you can see, when we did her blood, her liver function test was not really that remarkable. There was just a slight elevation in her AST, but based on the history, we had suspected that maybe she could be a relapse. So we did an autoantibody titers, and we still found that she still had significant anti-LKM with a titer of 1 in 320. So we then proceeded to do another liver biopsy because we're not sure how long this non-compliance had been going on for and when exactly they stopped the treatment. So we wanted to further assess whether there was worsening of disease from a histological point of view. So this is her liver biopsy, the second one, which showed portal tract expansion with lymphocytes, histiocytes, and plasma cells. There were focal areas of interface activity. There was no steatosis or apoptosis or necrosis that was noted. So at this point, we sat down with the parents and explained to them the findings, that although she had been doing well for the past 2 years and her enzymes had actually been normal, her biopsy still shows that she still has autoimmune activity that's going on, as well as her autoantibodies that were persistently elevated. So we did adherence counseling and we restarted her on prednisone and azathioprine. They went home and she was seemingly doing well until, again, when she presented about 4 weeks ago. She presented following an adenovirus infection. The parents had done bloods and enzymes were very elevated. If I can just go back to the previous slide. So if you can look on the 24th of October, that's when she presented with the adenovirus, where she had an ALT of 1,100 and an AST of 781. Her Baileys were also still not raised. The gamma GT was also elevated at 84. So at this point, we queried whether it was a viral induced flare, and we opted to rather watch the liver function test and see if she was not settling after 2 weeks of just observing her, then we were going to investigate further. We also queried whether this was related to non-compliance, since the patient had stopped treatment prior, exactly a year ago, actually. So this is a repeat biopsy, which was done last week. So this shows that all portal tracts are expanded by mixed lymphoplasmacytic inflammatory cells. There is interface activity, there is no granuloma, there is no viral cytopathic effect, and there were no features of cholangitis that were observed. So with this patient at this point, so this was last week, so we're still, again, querying whether there is an issue of non-compliance, although the parents are adamant that they have been giving the treatment properly. The other thing that we also considered that could be contributing to this picture, where she's actually not settling in terms of her liver biopsy and her auto antibodies, as well as the fact that she is now 3 years old. She's on azathioprine. When we look at the dose of azathioprine, it's actually not appropriate according to her weight, but we have a challenge with azathioprine because it only comes in 50 and 100 milligram tablets, and we don't have a syrup form for it. So we're not sure whether she's getting the ideal dose that she should be on. Actually, she's not, because we are not able to break down the tablet or mix it in any other way. It's either you're giving 25, 50, 75, or 100. So monitoring for drug levels is also not available. So we're not sure whether this treatment is actually optimal or not. So at this point, we've opted just to continue her treatment with steroids. So at this point, we increased her steroids again, and we'll monitor her liver function test. When they start improving, that's when we'll start weaning, and we will watch her to see whether she's going to go into remission, or if she's going to fail to gain remission, in which case then we might need to step up our treatment. So getting into our topic, autoimmune hepatitis. So this is a diagram which actually illustrates pathways in which autoimmune attack actually happens on the liver. It's actually a nice diagram to look at because it actually also shows you the different targets which drugs actually act on in order to prevent this autoimmune activity. So despite the presence of autoantibodies and plasma cell infiltrations, autoimmune hepatitis is actually considered a T-cell disease. And this is because the B-cell activation is actually a T-cell dependent event. So how it starts is that you'll have your autoantigen peptide, which is presented to the T cell receptor of an uncommitted T lymphocyte. When this happens, in the presence of interleukin-2, the uncommitted T helper cell then differentiates into T helper 1 cell, and in the presence of interleukin-4, it differentiates into T helper 2 cells. So with the T helper 1 cells, they further then differentiate into cytotoxic T lymphocytes or activated macrophages, which all have different inflammatory responses onto the hepatocyte. The T helper 2 cells also produces a lot of interleukin or cytokines rather from interleukin-4, interleukin-10, 13, and 21, and this activates the B cell into a mature plasma cell, which then releases autoantibodies. So all these inflammatory processes are usually kept in check by the T regulatory cells. So if there is any malfunctioning of the T regulatory cells, or there's a defect in the number of the T regulatory cells, then hepatocytes damage ensues by all these multiple inflammatory pathways that are shown here. So this is basically, just an illustration of how we eventually end up with hepatocyte damage and inflammation. So diagnosing autoimmune hepatitis. So the diagnosis is based on clinical, laboratory, and histological findings. So the clinical presentation for these patients is very varied. So it can range from acute onset with patients presenting with non-specific symptoms, which are similar to viral hepatitis. You can have patients with features of acute liver failure with encephalopathy, and it's actually reported that up to 67% of cases do present with acute liver failure. Some do present late with complications of cirrhosis and portal hypertension, and sometimes it's just an incidental finding where you are investigating for something else and you notice that the aminotransferases are raised. The other factor is your compatible histological findings, which I will discuss in the next slide. These patients also have elevated aminotransferases. They also have elevated immunoglobulins, but not all the time, as you saw with our patient. They also have positive serological markers, which I will also discuss. It is also important that when you are waking these patients up, you also exclude viral causes of hepatitis, as the serological markers and histological markers can be similar to those of autoimmune hepatitis. It's important to also exclude metabolic causes and drug-induced liver disease, as well as non-alcoholic steatohepatitis as well. So with the autoantibodies, there's two types of autoimmune hepatitis. So it's classified into autoimmune hepatitis type 1 and type 2 based on the autoantibodies that are actually positive. So with autoimmune hepatitis type 1, you generally find positive anti-smooth muscles and positive ANA. So there are other autoantibodies which get tested for, but I think mostly what's available in most of our labs is the anti-smooth muscle and anti-nuclear antibodies. The soluble liver antigen, which is reported to be present in about 22% of the patients with type 1 autoimmune hepatitis, and it has a high specificity for diagnosis, which is reported at 99%. P-ANCA as well, reported in 50 to 92% of patients with autoimmune hepatitis, although this is not specific because it's an autoantibody that you can also find in PSC, autoimmune hepatitis, PSC overlap, or even ulcerative colitis. The other autoantibody associated with type 1 autoimmune hepatitis is anti-actin, which is actually a subset of smooth muscle antibody. And it's also reported to be present in 86 to 100% of patients with autoimmune hepatitis who are anti-smooth muscle antibody positive. So for these antibodies in children to be required to be regarded as positive, the anti-smooth muscle and the ANA, you'd have to have titers of above 1 in 20. And then with autoimmune hepatitis type 2, the autoantibodies associated are anti-liver kidney microsome and liver cytosol antibodies, and the titers that are regarded as positive here are more than 1 in 10. With liver cytosol 1, about 32% of children with anti-liver kidney microsome will have this antibody positive, and they say that it's usually seen in children that have severe disease. And then the histology. So diagnosis cannot be made without histology and compatible findings in keeping with autoimmune hepatitis. However, it's also important to note that none of the individual histological findings are actually specific for autoimmune hepatitis. Like I said, with viral hepatitis, Wilson's disease, you can have features that are similar to those that you can find in autoimmune hepatitis. So they mention interface hepatitis as the histological hallmark of autoimmune hepatitis. But yeah, it's also observed in other diseases. Other features that you can also look for is portal lymphoplasmacytic infiltrates. There can be features of enteropoiesis, rosette formation, and central perivenulitis. Features of cirrhosis can be found in up to 38% of pediatric patients, and those values are actually comparable with those of adults, where it's reported that up to 33% of them can actually present with cirrhosis at diagnosis, and this is associated with poor outcomes in terms of needing transplant and also mortality. And then there's the subset of patients with autoimmune hepatitis in acute liver failure. So histological features of these patients predominate in the central lobular zone, and it's said to consist of central perivenulitis, plasma-rich inflammatory infiltrate, massive hepatic necrosis, and lymphoid follicles. There's also noted that these patients tend to have hyaline droplets in Kupffer cells. So those are the histological findings that you would be looking out for. Genetics and genetic predisposition. So genetics play a role in predicting outcomes to treatment, in predicting response to immune suppression, and also in determining which patients will actually have severe disease. So there are some countries that have done studies to see which genes are more prevalent in their populations. So the genetic association with autoimmunity is on chromosome 6, which is where the HLA complex resides. So in adults, the susceptibility to autoimmune hepatitis type 1 has been linked to the HLA-DRB1 alleles. With the HLA-DRB1 loci 0301 and loci 0401 alleles noted to actually predispose Caucasian adults from Europe, North America, and Iran to autoimmune hepatitis type 1. Whereas in Japan, autoimmune hepatitis type 1 is associated with DRB1 loci 0405, and then 0404 is associated with autoimmune hepatitis for patients in Mexico. Studies in pediatrics are quite limited. There's only reports from Europe, Egypt, and Brazil that I was able to find. So in Europe, autoimmune hepatitis 1 is similar to adults, and it's associated again with HLA-DRB1 loci 03. So that gene makes them susceptible to the autoimmune hepatitis. And then DRB104 was also noted in pediatric patients not to predispose to childhood autoimmune hepatitis. And in fact, it was found to be protective. In Egypt and Brazil, the alleles that they found which is predisposing was similar to that which was found in Europe. HLA-DRBs loci 3 and loci 7 were found to be associated with autoimmune hepatitis type 2. So all of these findings are from studies, like I said, in Europe and Brazil, and in Africa, there's only this report from Egypt. So there is very positive data in South Africa with regards to the genetic predisposition and the rest of Africa in terms of what genes predispose our children here, which patients would be susceptible to poor response and more severe disease. So I think more studies actually still needs to be done in order to determine all of this, because I think it will also be helpful in terms of predicting the outcome for patients and knowing how to counsel them from the get-go. Then there's a concept of seronegative autoimmune hepatitis, which is actually a challenge with diagnosis. So seronegative autoimmune hepatitis is a diagnostic dilemma. There are no autoantibodies that are present and sometimes patients do have other features that are partially or completely support the diagnosis of autoimmune hepatitis. There is a prevalence of 5 to 20% of seronegative autoimmune hepatitis. In South Africa, there was a study that was done in Red Cross War Memorial Children's Hospital in Cape Town, where they looked at characteristics of their patients with pediatric autoimmune hepatitis, and they found that 36% of their cohort actually had seronegative hepatitis, but they queried whether this high number was because of if it was related to the laboratory testing, because the International Autoimmune Hepatitis Group recommends that we use immunofluorescence technique as a standard method for antibody testing. And some of the labs here use immunoassays. So they queried if maybe some of the autoantibodies were actually being missed depending on the method of testing, because the method that they used was not the one that was recommended by the International Autoimmune Hepatitis Group. These patients, as I already said, have absence of autoantibodies, and they have a normal IgG. However, this IgG is noted to actually drop even further once the patient has been commenced on treatment. Patients with seronegative autoimmune hepatitis are also noted that later on they can develop aplastic anemia, and this is usually preceded by lymphocytopenia. This is just a table which summarizes the difference between the seropositive and seronegative autoimmune hepatitis. So I'm not going to go through it because it's stuff that we've already spoken about. And then this table is a diagnostic a table that has features that you look for when you make a diagnosis. It's from the International Autoimmune Hepatitis Group, where you look at the features that the patient has, as I already said, the immunological, the histological, biochemical, presence or absence of extrahepatic autoimmunity, family history as well, and whether the patient did cholangiography or not. And then you put in the score, and it will tell you whether the patient is a probable or a definite autoimmune hepatitis. I found this to be not entirely reliable, if I could put it like that, because if you look at our patient, she only had a positive anti-LKM in the beginning. Her liver histology was not really suggestive. So the only feature that she had in the beginning was an anti-LKM with titers more than 1,000, which were actually quite significant. So she actually didn't even meet a score of a probable autoimmune hepatitis, and yet she was actually treated as such. So with regards to that, there's been a meta-analysis of 4 studies pertaining to the accuracy of the revised criteria, of this revised diagnostic criteria. And they showed that this scoring criteria is actually 77% sensitive and 95% specific. So, yeah. Other associated autoimmune disorders. So concurrent diseases are usually associated with few or no symptoms. So it's actually important to screen for these patients. In rare instances, they can have symptoms severe enough to actually obscure the liver disease. Frequency of celiac disease in these patients is higher than the general population. So in the beginning, when you make the diagnosis of autoimmune hepatitis, it's advised to just always screen for celiac and thyroid disease. So thyroid disease has been noted to be present in about 23% of patients with autoimmune hepatitis. Celiac disease was found in about 10%, and ulcerative colitis was found in up to 20% of patients with autoimmune hepatitis. And this is usually associated with a positive family history of autoimmune diseases. So it's important to keep looking, because even if you don't diagnose it in the beginning, later on in the disease, they may develop symptoms of other autoimmune disorders that might need attention. And then once you have assessed and made the diagnosis, there is a few things to check prior initiation of treatment. So the aim of the pre-treatment evaluation for these patients is to limit treatment-related complications and ensure optimal therapeutic response. So one, you look if they have associated autoimmune disorders, because those will need to be addressed. Check for infections. We are in South Africa with a high prevalence of TB. Exclude TB before you start immune suppression. And then check for other systemic diseases that require change or dose monitoring. For instance, if you're going to be starting high dose steroids in a patient that's diabetic. It's also important to check vaccination status for these patients. So live vaccines are not recommended for patients that are on immune suppression. However, the inactive or recombinant vaccines are actually safe. So for patients that are not vaccinated against hepatitis A and B, it's advised that they actually get their vaccinations prior to immune suppression, if that is possible. The other thing to check prior initiation of treatment, because part of your first line treatment is prednisone and azathioprine, which I will go through, is testing for your TMPT activity, so your thiopurine methyltransferase activity, which picks up patients with 0 or near 0 TMPT activity, who are actually at risk of myelosuppression. It's also important to note that the myelosuppression is noted to also occur in about 0.5% of the normal population. So even those who have the normal enzyme activity, they can still get myelosuppression. The other important thing is counseling with regards to compliance, and also just talking about the side effects of the medication so that they actually know what exactly to expect. So this diagram here, or picture, is an overview of the mode of action of your first line, second, and third line treatment. So I thought it actually summarized it quite nicely. So your first line treatment is made up of your steroids and azathioprine. So the steroids bind to cytosolic glucocorticoid receptor, which migrates to the nucleus of the cell and causes inhibition of pro-inflammatory genes and activation of anti-inflammatory genes. So that will be the function of your steroids to inhibit inflammation. And then azathioprine and MMF inhibit the synthesis of purines, which are substrates of DNA and RNA synthesis during the S phase of the cell cycle. And this causes cell death of rapidly dividing cells. The second line treatment is your calcineurin inhibitors, which act by suppressing synthesis of the interleukin-2. Interleukin-2 is essential for T cell proliferation, so they inhibit or suppress the interleukin-2. Then there is the sirolimus and everolimus, which act on the mammalian target of rapamycin, and this also inhibits cell growth and proliferation. And then there's the anti-tumor necrosis factor, which interferes with the action of TNF. So these are the treatment recommendations. These are guidelines from the International Autoimmune Hepatitis Group. So they divide treatment based on induction and maintenance, and also based on how the patient has presented or how the patient has been diagnosed. So if it's just an autoimmune hepatitis without cirrhosis, then the first line of treatment would be your steroids. The European guidelines do not include budesonide as part of their first line treatment. So depending on which guideline you're using, it's either you do prednisone and azathioprine, or budesonide and azathioprine. And with azathioprine, as I said, it's important to check your TMPT activity. And then you add it 2 weeks after initiating your treatment, and you review your results. So I won't go through all of this. It's just basically an algorithm to show you how to step up your treatment, when to reassess a patient who is not responding properly, when to reassess to check if you've made the correct diagnosis, when to consider step up treatment, and when the patient is ready for transplant evaluation. Yeah. So assessing response to treatment. So for a patient who's responded well to treatment, they will go into remission, which is a complete recovery of transaminases, and they then become within the normal range. It is reported to be achieved in about 60 to 90% of the patients. Clinical remission is considered complete when the transaminases and the immunoglobulins are normal, as well as negative or low autoantibodies. So for the type 1 autoantibodies, they're considered low if they're less than 1 in 20, and the type 2 if they're less than 1 in 10. Histological resolution of inflammation is also considered as part of remission, but it's important to note that you can have a patient that has clinical and biochemical remission but still has ongoing autoimmune activity. Clinical and biochemical and immunological response, like, yeah, I just said, it does not always reflect histological response. Treatment cessation. So when is it safe for us to stop the treatment? So the guidelines suggest that for patients that have been on treatment for at least 2 to 3 years with normal immunoglobulins and transaminases for at least 1 year. And for pediatrics, they recommend that we always do a liver biopsy prior to cessation of treatment. Success in withdrawal of treatment ranges between 20 and 45%. Some patients do have disease relapse even if they are compliant on the treatment. It is reported that 60 to 80% of patients will relapse, and this is evidenced by elevation in the aminotransferases. The relapse is said to be typically asymptomatic, so it can happen that this is detected late. So there is an increased risk of hepatic fibrosis and clinical deterioration with these patients because they are typically asymptomatic. However, once it's picked up that they have relapsed, they rapidly respond to treatment. 50% of the cases are said to relapse actually within the first 3 months. Predisposing factors to relapse are duration and completeness of active disease prior to treatment withdrawal, and steroids that are administered on alternate days. So there are some people who do give steroids on alternative days with the thinking that giving steroids on alternative days will actually reduce your side effect profile of the steroids, but in the long run, it actually predisposes your patient to disease relapse. Other proposed factors which can contribute are things like psychological stress, other concurrent autoimmune diseases, and treatment with multiple agents. So second line therapy, which I mentioned, it would be your calcineurin inhibitors. This treatment is considered when a patient is having treatment failure, so worsening of laboratory and histological findings despite compliance with standard therapy, or for your patients with an incomplete response, which is marked by improvement of lab and histological findings that's insufficient to satisfy the criteria for remission, and this is reported to actually happen in about 15% of pediatric patients. The other reason you would consider second-line treatment is if the patient is intolerant to your first-line treatment and they are unable to continue maintenance therapy due to drug-related side effects. So second-line treatment would be MMF, which is mycophenolate mofetil. So it's given for patients with treatment failure and patients that are intolerant to azathioprine and prednisone. It has been noted that with MMF, it results in normalization of your enzymes by 6 months in about 36% of the patients. However, there is lack of knowledge with regards to the therapeutic range and toxic threshold for this medication. And it's also much more expensive in comparison to azathioprine. So that's the challenge with MMF. Calcineurin inhibitors, which would be your tacrolimus and your cyclosporin, comes second to MMF due to their side effect profile as well. But yeah, it's other drugs to consider. Third line therapy. So this would be your anti CD20, so your monoclonal antibodies, such as rituximab. So data supporting the use of this treatment is actually quite limited, with rituximab also associated with high infection rate. So whenever you're needing to use rituximab, then you must always consider covering your patient with prophylactic treatment for CMV and PCP. So for our patients that we use rituximab on, we always cover them for PCP with Bactrim prophylaxis and Valsite for CMV prophylaxis. And then there's your mTOR inhibitors, which constitutes everolimus and sirolimus. But like I said, data supporting the use of this treatment as third line is actually quite limited. Then there are some experimental therapies at the moment. So there is ianalumab, which is a monoclonal antibody targeting anti-B cell activating factor receptor. So anti-BAF. So BAF is a cytokine receptor that promotes the proliferation and differentiation of the B cells. So in contrast to the CD20 or monoclonal antibody, your rituximab, which is expressed in early stages of the B cell, this targets the B cells before proliferation and differentiation. So this treatment at the moment is currently in a multi-center randomized double-blind placebo-controlled trial. I think then phase 2 and phase 3, and they had started the study in 2018, looking into completion in 2025. So it will be interesting to see what the results of this study show in terms of other therapy options, and also whether this will be affordable for our population or not. Yeah, so that is the experimental, the trial that they are busy on at the moment. The other treatment is it's anti-TNF. So the tumor necrosis factors are cytokines that are produced by macrophages and effector T cells, and then tumor necrosis factor, through a complex of signaling pathway, results in a wide range of pro-inflammatory responses, including activation or proliferation or apoptosis. This results in inflammation and necrosis depending on which receptor is activated. So there are arguments linking tumor necrosis factor alpha signaling pathways to the pathogenesis of autoimmune hepatitis. And high levels of tumor necrosis factor alpha have actually been found in blood of patients and hepatocytes of patients with autoimmune hepatitis. So this is where this anti-TNF treatment actually also comes through. So the treatment here would be infliximab, which is rescue therapy in difficult to treat patients. It reduces inflammation, but again, there is a high rate of infectious complications, and it may also cause idiosyncratic hepatotoxicity. Interest in the use of infliximab as an induction therapy is being looked at. There's a clinical trial currently going on in Germany looking at this drug as an induction of therapy. But again, caution will have to be used in terms of high rate of infectious complications and prophylaxis. And again, costing is also another thing for patients in our population in terms of treatment options. Liver transplantation. So 2 to 5% of pediatric liver transplants in Europe, the United States of America, and India are patients with autoimmune hepatitis. The United Nations organ sharing database revealed that in their 10-year review of patients with autoimmune hepatitis that were transplanted, their 1 and 5 year survival rates were actually 94 and 91%, respectively. And then in India, they also did a study which showed that their 10-year cohort survival rates were 77 and 70% at 1 and 5 years, respectively. With transplant for autoimmune hepatitis, disease recurrence is one of the complications post-transplant, with 23% of the patients having recurrence in the first 5 years post-transplantation. Recurrence is less frequent in patients transplanted for acute liver failure versus those that have been transplanted for chronic liver disease. Again, there is positive data with regards to survival rates for patients in South Africa that have been transplanted for autoimmune hepatitis. There's been a retrospective review that was done for adult patients in a hospital in Johannesburg, where they also reviewed their post-transplant patients with autoimmune hepatitis. So they reviewed the characteristics of the patients and actually found that Black Africans had a 4-fold higher rate of rejection when compared to Caucasians. Recurrent autoimmune hepatitis was actually only found in Black Africans, and 5-year graft survival was significantly lower than Caucasians. But what could the contributory factor to this be? Is it genetics? Is it environmental? It is not exactly clear why these differences are like this, but it's something to consider, to look at in terms of our outcomes for patients transplanted for autoimmune hepatitis. And then the other thing that I thought to put in was just assessing our patients as a whole. So this is so health-related quality of life. So we know that chronic liver disease has been shown to be associated with reduced health-related quality of life, even in the early stages of the disease. So this is a cross-sectional review of children in a GIT clinic in Cleveland using the therapeutic quality of life score, which showed that most of this patient actually had significantly reduced health-related quality of life when compared to healthy children and other children with other chronic liver diseases. So the scale, when they look at it, they incorporate your physical, emotional, social, and mental domains. So that's what the score is all about. And yeah, patients with autoimmune liver disease have low health-related quality of life. So it's something to consider when we make the diagnosis, treatment options, something to look at when we follow up our patients. And that is it. Thank you so much.
Thank you, Vusi. That was an excellent talk. I enjoyed it. Thank you.
Thank you.
I don't have any questions in the chat at the moment, but I did see that some of the authors of the Red Cross paper were online. So I don't know if they've got anything to add to their experience in autoimmune hepatitis in South Africa. Not sure if I'm putting them on the spot, so I'll give them a chance. But I also wanted to ask you, as in the private setting, if you're also seeing so much seronegative autoimmune hepatitis, or is that more to do with perhaps the lower quality laboratory tests that we see in the state?
So in private, we do have access to immunofluorescence testing. That is the recommended testing. So since I started, I haven't seen any new diagnosis of a seronegative autoimmune hepatitis, but I've seen plenty with positive autoantibodies.
And that's helpful. I don't see any questions or any hands. Oh, yes, there is a hand. Mohammed, do you want to unmute yourself?
Yes. Okay. Thank you, Vusi. Thank you for your nice presentation. Just I have two questions about, because you mentioned your presentation about the TPMT, but I don't know, I think I missed it, or I don't know, I didn't see in your workup the TPMT for this patient. That's the first thing. And the second question, what's the indication? Because I saw you repeated the liver biopsy 3 times. So what's the indication for the liver biopsy 3 times? Because we know it's some invasive procedure. Maybe if we are looking for the cirrhosis, maybe the other way to do the fibroscan, which is it's more informative for the cirrhosis or fibrosis. And the other thing, what's the rule in this patient? The last question, that what's the role of the MMF in this situation? If we address the compliance and the family denied about the non-adherence, and we saw that, so what's the rule for the MMF? Yeah, thank you so much.
So TMPT enzyme activity for this patient was not done. As to why I am, but it wasn't done. Your second question was about the repeated liver biopsies. I think
Yes.
The biopsies were done to assess if there was any further progression of disease. But I do agree with you in terms of using fibroscan, because that is less invasive. I don't know if there's anyone that has a differing opinion with regards to that.
The role of the MMF, the second line, if we address the compliance issue. So in this situation, to go to the second line.
Yeah, so for this patient, I do think that if we do address the compliance and we monitor the patient and we do see that there isn't an improvement at all with the enzymes despite compliance, then we will definitely have to consider second line treatment, and MMF, we do have access to it. So I think that we might consider starting her on that.
Okay, thanks. Thank you so much.
I think also with regards to the second biopsy, I mean, I don't know the patient, but the second biopsy certainly was also the question of the diagnosis, because your first biopsy was not typical at all. Chris, you raised your hand.
Yeah, Tim, thanks very much. Thanks for signing. Just a comment on treatment. I think autoimmune is really a little different in that it is insidious, and really we need to achieve absolute normality of enzymes when treating these patients, because often there might not be good correlation once you've established the diagnosis between the improvement in enzymes and also what happens on biopsy as far as fibrosis or ongoing liver disease is concerned. So we drive the drugs often at the expense of side effects to achieve normality. Differs a little from other diseases of the liver.
Other hands or comments that I'm missing? I don't think so at the moment. I think it was also interesting that your one of your relapses, there was very high ASTs compared to the other transamin or to ALT. And I was just wondering if you had also had any hemolysis, autoimmune hemolysis, or even considered other autoimmune diseases in this child.
So when she came in now with this elevated enzymes, her HB was absolutely normal. So we actually didn't pursue a hemolytic screen or a workup for that at all.
I think that is it in terms of questions. I have a last look at everyone to make sure I don't miss anything. But otherwise, just to thank you again, Vusi, and to thank everyone who's presented at Pathophysiology through the year. Without you guys, obviously, there wouldn't be a Pathophysiology. So thank you. Thank you also to the audience for always attending and having interesting questions. I need to also thank the Gastro Foundation for hosting these webinars, and iEcho New Mexico, as well as the iEcho India team, who do the sort of logistical background work for this. The recordings for the presentations are available on the Gastro Foundation website. So if you missed something, you can always go back and see it. Big thank you to the sponsors. Again, without them, there wouldn't be a Gecko. So thank you very much. And for those of you who want to know what's happening next week, it'll be HCC at this time next week. So thank you very much, everyone. Have a good evening. And thank you, Vusi, again for presenting.
And Tim, thanks very much for taking control and keeping the presentations up. Very, very nice. Thank you.
Pleasure. Bye.